It's sharp 9, sir. With all your due permission, can we begin?
Yeah, sure.
Good evening, everyone. This is Batul from IJCP, and I would like to welcome all the viewers who have joined our platform for the better exchange of knowledge that is going to be shared by our renowned speaker for today's session. Well, sir needs no introduction at our platform, but it's my pleasure and honor to introduce him. He is none other than Dr. Vijay Varat, sir. Sir is MBBS, MD consultant allergist, pediatric pulmonologist, clinical immunologist, consultant at Allergy Asthma Eye Hospital, Shayadri Hospital in Amdar Multispeciality Hospital. With Sir's help, we'll be talking about the topic for today's session, which is biologics and allergy. So now let's welcome Sir at our forum to know more about the topic. Without any further delay, I would like to welcome Sir. Sir,
Yeah,
over to you.
Thank you. Thanks a lot for introducing me. Thanks IGCP for having such type of webinars to educate the doctors. And I always learn through my lectures also because of the interactions with the delegates. See, basically, as we all know, the allergy has been a very important disease nowadays. It's one of the very disabiliting, which has a lot of morbidities, and even at some times it is causing a life-threatening complications also. So allergy is one of the chronic disease, like how we manage the diabetes, blood pressure. The same way, it should be given the importance. And while managing this disease, at present in Indian scenario, a lot of oral parenteral steroids are used to have the control on the disease. But these oral or parenteral steroids have a lot of side effects long term. It's like whatever the management is done now, specifically, we are finding these are like these oral or parenteral steroids are like a nuclear bomb. Like we use it, it gives the immediate results, but it acts on a different parts, having a lot of side effects. When worldwide, a lot of research has been done. The research and scientific based treatments have proven emerging therapies, like these are called biologics. They are the target therapies, and how they act like a surgical strike at a right place where there is a pathology, and how they reduce the inflammation and reduce the allergy symptoms and long-term control of the disease also. We will see. The most important is that allergy is a hypersensitivity disease. Still in Indian scenario, a lot of doctors also, they say to the patients that you have a lower immunity and that's why you are having a repeated symptoms. But it is a hypersensitivity disease. So we have to understand that it is a hypersensitivity, it is not a lower immunity. So the sensitization to the allergens, which goes on increasing into the body from one to few to multiple, when the minimal persistent inflammation increases to that level where the overflow of symptoms starts, and when the patient starts having allergy attacks. So even the Chase Research Foundation, which was there in Pune previously, along with the Doctors Republic side, they did a survey, and people think that cancer, diabetes, they are having a second death causing disease, but it's not that way. Even the chronic respiratory diseases, which is a second death causing disease in India. And because of the changing lifestyle, adulteration, pesticide use, colors, odors, then genetic environmental changes, even the increased admissions because of the food allergies have gone up 7 to 8 times into the children's. In Lebanon 2019, novel approaches to the worldwide allergy epidemic has been declared. A lot of cases are increasing. So there are multiple factors along with that. Even the skin sensitization or cutaneous sensitivity, the dendritic cells in the skin, they get sensitized because of their grain, their dust, or any dust mites. And slowly the sensitization increases, and overall the mast cells get hyperactivated. And then the gut mast cells, the dendritic cells, they get stimulated because of the oral foods, and then nose mucosa or eyes, they also get, and even the skin also gets sensitive afterwards. And then the patient starts having symptoms. So as a practitioners, any doctor, our role is that to control the symptoms with the safer medications, to stop the allergic march or progress of the disease inside the body, leading to the newer sensitivities and the further inflammation cascade. Because in between there can be a window period, like suppose a child is having a eczema or the gastrointestinal colics, GERD, 40% have a food allergies. They may overcome those symptoms. Many of the children, they overcome the food allergies within 5 to 9 years. But later on, their newer sensitivity to the pollens increases and they go into rhinosinusitis, rhinoconjunctivitis, severe viral rhinosinusitis, asthma, chronic respiratory diseases. That is worrisome. So it's already one of the third leading causes of chronic disease amongst all ages. First common chronic disease amongst below 18 years children. Even 2023, the significant allergy will increase such a way that every third person will be suffering with a very significant allergies. Even asthma, childhood asthma has increased a lot. Most of the children, wherever are they at home, they are having a nebulizer, inhalers. Somebody is taking homeopathic, Ayurvedic, Unani, electropathy, some other treatments. But out of these, children with asthma, 90% have an underlying allergy. Even adults with asthma, 65 to 80% have a positivity to the allergen sensitizations. So as I mentioned, the COPD is already increased, and you can see there are papers also from 2017 onwards. Asthma COPD overlap syndrome is well documented now. There are a lot of ACO, ACO cases, asthma COPD overlap. These are increasing. And considering like most of the people are worried about asthma, I have chosen that in allergy. Like it's a heterogeneous disease. Severe asthma around 5 to 10%. So if you see the population of the world, considering that, significant case have increased. Biomarkers can help determine the risk of exacerbations, complications, possibly predict and monitor the response to the treatment. And biologics therapies, these are the add-on therapies for poorly controlled or uncontrolled severe asthma, even moderate to severe asthma also, or allergies. We'll see how. IL-3, IL-4, IL-5, IL-33, IL-13, TSLP biomarkers are used in diagnosis for phenotypes and to have targeted therapy as steroid sparing treatments. As I mentioned in the beginning, steroids are overused, parenteral or oral, and where rather than using a bomb to kill the ant, you have a surgical strike and use a specific target therapy at the interleukins. So again, these specific receptors and in turn the basophils and eosinophils, these are the cells which again have a therapeutic treatment role. So at our hospital, few years back, actually we did a studies on these patients, and significantly we found that IL-4, IL-7 proliferations on the Th cells. Th2 cells were increased in these patients, and this endogenous IL-3 neutralization or Th2 suppression has helped these patients to reduce the inflammation and symptoms also. During the COVID, at least, we have seen the IL-6 levels, how they are useful, and they are routinely done during the COVID. But allergy is before that, but still the awareness is lacking amongst the community to go for the targeted therapies and to analyze that. That's why these tests are still not done in most of the countries. And if you see the T helper, healthy individuals and those patients with the allergy, they had a significant Th2 inflammation. How these biologics they act? These are the natural extracts. These are the natural monoclonal antibodies from human cells. So very less side effects. And in the IgE allergic cascade, we all know like specific allergens leading to the specific IgE formation, and which stimulates the FcRn receptors on the mast cells, and which leads to the reactions, the histamine, lymphokines, cytokines. These markers are mediators, inflammatory mediators are released, and the patient has symptoms. So even the other cells like eosinophil, basophils also get here. And omalizumab, which has been very well studied since many years, it has effects on all these levels. So it has a multiple actions. So that's why it is a favorite drug still even having so many other targeted therapies. Omalizumab is used in multiple cases, from food allergies to anaphylaxis to even eczema, urticaria, asthma, rhinosinusitis, polyps, rhinoconjunctivitis. We have around more than 450 patients of rhinoconjunctivitis, which is more dangerous than the asthma, which is causing a lot of trouble because of the rubbing, causing a friction, keratoconus, then glaucoma, cataract because of the repeated eye steroids, affecting adolescents with the keratoconus. And at the age of 22 to 25, requiring a cataract and glaucoma surgeries. There also we use the omalizumab, which has a very good efficacy. Then, as I mentioned about the interleukin 5, the anti-IL-5 therapy in eosinophilic asthma. So, which are those? Mepolizumab, reslizumab, and benralizumab. Amongst that, mepolizumab and benralizumab is available in Indian scenario. So these IL-5 targeted agents decrease the asthma exacerbation in patients with severe asthma who have high blood eosinophil levels. So, when we want to give a mepolizumab, benralizumab, then we require a eosinophilic, higher eosinophil count. And these patients clinically, most of them have adult onset asthma. And children which have a childhood onset allergy or asthma, the omalizumab also works very well. So late onset or adult onset asthma, there this interleukin 5 have a bigger role. So there maybe the omalizumab may not work that effectively, but these mepolizumab and benralizumab, they act at the IL-5 level. So all these cells, eosinophil, basophils, and mast cells, their increase gets arrested, they get controlled, and because of the mediators of the inflammatory cascade are reduced, and they have a very good response. So mepolizumab acts on the different pathway, and benralizumab directly acts at the IL-5 R alpha. So again, it is more targeted therapy for that reason. Then anti-IL-4, IL-13 therapy in eosinophilic asthma, which is dupilumab. This molecule initially came with for the eczema, severe eczema patients. And now even above 6 months, some of the countries it is used. So this is anti-IL-4 receptor therapy, blocks the IL-4 and IL-13 mediated inflammation. So where the eczema patients, they have a very good efficacy, as well as nowadays, even it will be having a use in asthma, as well as VKCs, viral keratoconjunctivitis, with underlying allergy overlap. So these targeted therapies will definitely help. So dupilumab acts at these Th2 cells at this IL-4, IL-13. So in turn, the eosinophils and the mast cells, their inflammatory mediators are reduced. The patient have a very good. So anti-Ig monoclonal antibody, it's a recombinant humanized monoclonal antibody against Ig, indicated for moderate to severe asthma in patients more than 6 years old, inadequately controlled with inhaled corticosteroids. Only biologic currently approved in the United States for patients 6 to 11 years old. Even some trials are happening about 2 years. Subcutaneous administration 75 to 375 milligram every 2 to 4 weeks. Up to 600 milligram also we can go. Limit injections to less than 150 milligram per site. Dose determined by body weight. Serum total IgG measured before the start of the treatment. So there is a disc actually. It has calculated according to the weight and the level of the Ig. So at least 75 to 700 Ig when it is there. This is used. Above that levels, still the trials are not much. So that also can be used in these patients. Anti-IL-5 biologics for eosinophilic asthma. As I mentioned about that, mepolizumab, reslizumab, benralizumab. Mepolizumab, anti-IL-5 monoclonal antibody. Reslizumab, anti-IL-5, benralizumab is anti-IL-5 R alpha. So these are more specific target therapies. And practically in my few patients, we have seen a very good results with benralizumab. So mepolizumab 100 milligram every 4 weeks subcutaneously. Reslizumab IV infusion over 20 to 50 minutes, 3 milligram per kg every 4 weeks. Benralizumab 30 milligram every 4 weeks, 3 doses. Then 30 milligram every 8 weeks. Even up to 1 year, we can use it. Up to 5 to 6 years also. Some of the patients are using for 15, 20 years omalizumab. So depends on that. But most of the patients 1 year is sufficient. Till that time, after the proper standardized allergy test, we guide the patients about whatever the allergen management, whatever precautions to be taken, what some breathing exercises, integrated approach, then some mast cell stabilizers, montelukast, bilostine, montelukast, fexofenadine, higher dose of fexofenadine or bilostine also can be given in these patients to control the symptoms. Other targeted therapies for eosinophilic asthma, dupilumab, tezepelumab, favipiravir. Even now, we are doing a trial of itiquimab, which is against IL-33. So, a lot of research are happening about these monoclonal antibodies. Amongst that, dupilumab now is getting available in India. About 12 years it is available. And subcutaneous dose is 200 milligram or 300 milligram every 2 weeks. Slightly costlier than the other molecules. And what precautions should be taken during the A? There is some black box warning. 0.1 to 0.2% in clinical trials. There was anaphylaxis. Practically, in my scenario, I have used more than thousands of patients. Never I have found I have anaphylaxis. Precautions for hypersensitivity reactions. Dupilumab, benralizumab, mepolizumab. Cases of activation of herpes zoster reported with mepolizumab. So zoster vaccination recommended in patients more than 50 years old prior to therapy initiation. So depending on the research, so that's why actually these in allergy immunology, there's a lot of research is happening. These are research and scientific based treatment. So very few side effects, and at least they are known, and we can stop it also whenever it is required. But very few patients require stopping that. So for the severe Th2 inflammation asthma, we can see all these molecules and how the reductions in the frequency of exacerbations. Omalizumab 25 to 50%, mepolizumab 50%, reslizumab 60%, benralizumab 40 to 50%, dupilumab 50 to 70%. So depending on that, lung function improvement, omalizumab shown minimal, mepolizumab but not all studies. All phase 3 clinical trials, reslizumab, if eosinophilia is more than 400 cells, then benralizumab and all dupilumab, they have shown a very good lung function improvement. And corticosteroid weaning, you can see, decreases the total use of ICS and OCS. I think most of the cases, they have shown that results. Most of these biologics, they have reduced the oral or parenteral steroids. Does the patient needs a biologic? So which patients to give the biologics? Ways to improve the symptoms and reduce exacerbations in poorly controlled asthma. Increase access to ICS, long-acting bronchodilators. So in spite of this, we should use the ICS also. Encourage medication adherence and improve inhaler technique. Instruct an allergen avoidance. So without an allergen avoidance, if you directly give this, it is not useful. And in many cases, we have seen that even the allergy test is not done, and directly the patient is given omalizumab, mepolizumab. So that's not going to work for longer period, because these are the monoclonal antibodies. They just block at the receptor to reduce the mast cell and Ig binding to reduce the inflammatory markers. But these are not a disease-modifying therapies. So integrated approach, again, I will enlist on that. Whenever you want to treat these patients, at all the 3 levels, we have to manage. Those patients which require oral or parenteral steroids repeatedly, there only biologics have a very good role as an add-on therapies. But along with that, or even before that, when the patient has a mild to moderate, persistent, moderate, intermittent or persistent allergies, asthma, there only the allergy testing should be done, and the guidance to the patients about avoidance measures should be in. Otherwise, it is like that best insulin we are giving to the patient, and the patient having sweets, everything. Nobody has asked him to avoid that. So biologics may have a role in asthma management for patients who require more than 3 courses of OCS in a year, despite controlled medication adherence, require the chronic OCS to maintain the control. Selecting the right biologic in eosinophilic asthma. Is it allergic or non-allergic? If allergic and elevated serum Ig, consider omalizumab first choice. And as I mentioned clinically, the childhood onset allergies, allergic march, there it has a very good. If non-allergic, late onset, adult asthma, then anti-IL-5 as a first choice. All three have shown similar outcomes in clinical studies. Other considerations, targeting IL-5 directly versus IL-5 receptor route of administration and dosing effects on the comorbidities like chronic rhinosinusitis with nasal polyps, atopic dermatitis, patient weight, patient preferences. Accordingly, we have to decide how long should the biologic therapy be used. It's typically administered for 3 to 6 months before the assessing the response. So it's not like a steroid injections. We have to always assess the response within 3 to 6 months. And then only we have to continue it. If after 6 months the patient doesn't have much response, stop it. Omalizumab recommended duration treatment is unclear, but I have seen patients taking for 10 to 15 years also, but most of the patients up to 1 year it is sufficient. Some patients require a long-term therapy. Anti-IL-5s should be continued indefinitely in patients who respond quickly. Basically, because these are adult onset and the allergy may not have a role into that. So there, we may require for a longer period. And now most of these biologics are covered under the insurance. And patients are getting a benefit of it. Eosinophil increase 12 weeks after discontinuation of the mepolizumab. Even in some of the patients, there is no need to repeat the eosinophil levels immediately, or there is no need to repeat the total IgE. Because sometimes the IgE which is bound to the mast cells, it is broken from there. So the circulating IgE may take for some time. Biologics now in allergy asthma, they have become an important treatment. With severe asthma, not well controlled or unconventional therapy. So we have to select according to the asthma phenotype, route of administration and dosing, comorbidities, patient weight, patient preferences, efficacy also we have to analyze. So you can see like how molecular target based current future biologicals in scenario, omalizumab, mepolizumab, benralizumab, then tezepelumab, and even now we are doing one trial for the anti-TSLP. So before this thymostropyl lipoprotein, these biologics will act over there and they will be useful for most of the cases. Even as I mentioned, now World Allergy Organization has said out of allergic rhinitis, 95% have a allergic conjunctivitis. And what is more disturbing, and where except eye steroids, the patient doesn't show a good response. So again, eye steroids are having a lot of complications. So that's why even it is considered like one airway, one disease. Rhinoconjunctivitis. Now, rhinitis term has gone. Even 2023 JINA guidelines you must be seeing. There is a rhinoconjunctivitis everywhere mentioned. So it is now rhinoconjunctivitis has been included in one of the one airway, one disease. So this child, which had a Seals ulcer, which was suggested for the intraocular steroids, already started having a cataract. And once after the analysis, his IgE was also 110 and the turbinates hypertrophy was there. We started omalizumab. Within 4 months, he showed such a good recovery. His eyes got cleared, his inflammation went down, his Seals ulcer also came down. So such a benefits into that. And wherever in urticaria patients, when the systemic steroids are required, then 150 to 300 milligram every 4 weekly, the chronic urticaria, chronic spontaneous urticaria, omalizumab can be given. Even for the chronic urticaria, omalizumab and off-label use of dupilumab, reslizumab, mepolizumab, benralizumab is used. And this legilizumab and UV221, like basically specific some inhibitors are there, JAK inhibitors and all. They are also having a role into that. Those are the trials we are doing. So summarizing, over the recent years, research has provided immense progress in understanding the pathomechanisms of allergy disease and has unraveled new therapeutic approaches. With the development of novel therapies, we face a new era of disease management, safer one. And as I mentioned, it is covered under the insurance. So we should prefer wherever there is a steroid required. And there are number of unmet needs. Understanding the role of genetics, its interaction with the environment, monitoring disease severity, response to treatment, or preventing the allergic diseases. Okay. So in the future, we will have a lot of things. Thank you. Thanks a lot.
Thank you so much, sir. Thank you for such wonderful insights upon the topic. In spite of today being a holiday, you have taken out your valuable time and for being here at our platform and sharing such wonderful insights about the topic. So thank you to you and as well as all the viewers who were here connected with us and for their ardent participation. Well, one of our viewers is wishing you a very happy Raksha Bandhan, sir. So
Same to
happy
everyone.
Raksha
Thank you
Bandhan
all
to
of you.
all the viewers as well and to you too, sir. Yes, sir, you're saying something.
Yeah, thanks for that, and same to all of you, all the my friends and all which are listening to that. Yeah, happy Raksha Bandhan to everyone. Thank you.
Yes.
Yeah. Okay.
So
See
we
you.
have received another feedback from a doctor, Dr. Uma Chetri. She says, wonderful insight and presentation by Dr. Varat. Thank you so much for your knowledge sharing class. Thank you, Dr. Uma. Thank you for your feedback and for your appreciation. We have received another feedback from Dr. Mangesh. Dr. Mangesh is saying, nicely presented, sir. Thank you for clearing so many doubts. We would take our time to thank you, sir, because obviously without your insights and without your informations, this would not be possible to share the knowledge with the other doctors and the viewers who are here present with us. So thank you so much, sir, for your valuable time. As of now, there are no questions, but flooded with feedbacks. So thank you, because the viewers appreciate us and that is what we require. So thank you so much, sir. Thank you for your presentation and for your efforts. With all your last comments, sir, we can conclude the session here for today.
Yeah. Thank you for the faith by the doctors and appreciation for my talk. And the aim is that to improve the practices in our patients and to have a quality of life to the people, because last 34 years I have seen the allergy and clinical immunology. These are very well underestimated and overlooked in Indian scenario. And still so many oral and parenteral steroids are used. So at least the research-based and scientific treatments should be used to improve the quality of life and to stop the progress of the disease and complications. So thank you. Thanks a lot.
Thank you so much, sir. Thank you for such a valuable comment of yours. Thank you so much. So with this, we are concluding the session here for today. Until next time with Dr. Vijay Varat, sir. So thank you so much.